This program is brought to you by Stanford University. Please visit us at stanford.edu.
So it's a pleasure and honor for me to introduce my colleague Geoff Rubin this morning. So Geoff is a world expert in CTA and cardiovascular imaging and runs a great annual meeting that brings together thousands in this field. Geoff trained at Caltech and UC San Diego, and looking at your CV, it looks like this is 20 years now from when you first came to Stanford. So he's a professor of radiology. He's chief of the cardiovascular division within radiology and also associate dean at the medical school, and I think will be taking over too as chief of staff in the near future for the hospital. So it's great to have you here this morning. Thanks, Geoff.
Thank you, Mike. Thank you, Mike, for that kind introduction. Good morning, everybody. It's really a pleasure to be able to speak to you today. I wish I could have been present for more of the meeting, and I'll apologize in advance to some of the speakers later this morning. One of the challenges of being at your home institution and trying to attend a meeting is the competing scheduling. But I'm completely with you now, and so I want to talk a bit about imaging of abdominal aortic aneurysm as a lead-in to a number of talks that you'll be hearing this morning. And when one thinks about imaging of the abdominal aorta or the cardiovascular system in general, there are four primary modalities that one would consider, at least non-invasive modalities. I'm not including catheter-based angiography, which has largely been displaced in abdominal aortic aneurysm imaging other than for guidance of endovascular therapy. Sonography, CT scanning, MR, and scintigraphy are the modalities to consider. I'm going to tailor my comments in this talk toward clinical applications of imaging. Clearly, there are many very intriguing applications of imaging toward understanding the pathogenesis, pathophysiology, physiology of aorta and aortic aneurysms, but I know that some of the subsequent speakers will be stressing that. Similarly, because we'll be hearing dedicated talks on molecular imaging and functional imaging with MRI, I'm going to be largely focusing on CT, but I will make some other comments on the other modalities. Now, from the standpoint of imaging goals, there's really four, in my mind, areas clinically that one wants to apply imaging. First and foremost is the detection of aortic aneurysms. And the last question sort of brought up the intriguing subset of detection, and that is detection of preclinical disease versus the detection of clinical disease. I think it's fair to say right now that we do not have reliable indicators from an imaging perspective of the detection of preclinical disease, but it is only through subsequent investigation and looking at patients at risk and families at risk that we'll be able to detect those telltale imaging signs. But from the standpoint of detecting aneurysms that have developed, sonography really is the primary tool that is used and is a very effective tool because of its low cost and its very non-invasive nature in being performed. From the perspective of progression, then, once an aneurysm has been detected, imaging focuses largely on monitoring size, but another important element of progression is simply the evolution of the aneurysm toward a state where it's at risk of rupture. And I think, as we'll hear, progression can both mean changes in size of the aneurysm, but biological changes in the wall that might predispose one aneurysm to rupture at a smaller size than another aneurysm. And I'm not going to talk in more detail about that because I think we'll hear about some of those more functional studies subsequently. I'm going to concentrate my comments predominantly on using imaging for treatment planning, which is once the aneurysm has progressed to the state that something needs to be done, and then subsequently on the post-treatment assessment. These are MRI scans of a patient who has a large abdominal aortic aneurysm. These are projections, maximum intensity projections from an MR data set. And I show them to you because I think that they're a fairly good indication of the image quality that we have when looking at the lumen from a 3D MRA in MR imaging. A couple of other images here, two different types of 3D visualization techniques. This is called a maximum intensity projection. This is volume rendering, again showing the depiction of the aneurysm. But when it comes to treatment planning, it is very important to, as effectively as possible, display the extent of the aneurysm. And the extent of the aneurysm, we know, is something that not only relates to the lumen, but the wall of the vessel. And so imaging the wall is very important, as is the relationship of that abnormality toward branches of the aorta, angulation of the vessel, and other adjacent tissues. And one of the challenges that MR still faces in a standard clinical realm is its spatial resolution. These contrast-enhanced MRAs typically result in voxels, which are the fundamental imaging unit that is about 1 by 1 by 3 millimeters. And those scans are typically acquired in a stack of coronal planes. And when you reformat them transversely, here you can see an image of an abdominal aortic aneurysm. And there's little doubt, particularly when one has a calibrated measurement, that you can characterize this segment of the aorta as being aneurysmal. But when it comes to clearly defining the outer wall, particularly on this pulse sequence, it's certainly very challenging. And also, hopefully, you can appreciate that the spatial resolution in this direction is simply not as good as it is in this direction. Now, when occasionally with the contrast-enhanced scans, you can see and make out the margins of the aneurysm, as you can see in this particular case as extensive thrombus. But in general, one of the challenges of MR as routinely applied clinically is clearly delineating the full extent of the aneurysm, and to be able to do it in a manner that is an efficient clinical protocol. One of the strengths, though, that MR offers is the ability to characterize the composition of tissue. This is a fairly specific example of a patient who has an infected graft in the aorta following therapy of abdominal aortic aneurysm repair, but it nicely shows the impact of using T2 versus T1 weighting following gadolinium, showing enhancement as well as the fluid collection around the graft. There's a lot that MR has to potentially offer in terms of characterizing the wall of the vessel. But again, from the standpoint of treatment planning, this is not a core element. And I know we'll hear a lot more about using MRI for characterizing the wall of the aneurysm a little bit later. Now, in contrast, here is a CT scan using a multi-detector row CT scanner. In fact, this is a scan that we did just a couple of weeks ago, a patient of Ron Dahlman's, and I just sort of pulled it off of our PAC system as a general example that shows you the level of detail and image quality. This is done, of course, with an iodine injection, and in this particular case, we're focusing predominantly on the lumen, but the voxel dimensions here are on the order of 0.5 by 0.5 by 0.6 millimeters. So somewhere on the order of 10 times smaller from a volumetric perspective than the routine MRI acquisitions. And hopefully you can appreciate in terms of the distinctness and crispness of the vessels and being able to appreciate some of the more nuanced morphologic characteristics of the aneurysm. Moreover, with the single acquisition, one sees both the lumen and the wall. And in this particular case, you see the critical observation that this aneurysm is extending well beyond the aorta into the common iliac artery here, involving the majority of the common iliac artery, which necessitates consideration at the time of repair to make sure that one goes beyond this area of abnormality if one is going to deploy a stent graft into stable tissue or if one is going to perform an open bypass procedure. Also in this patient, and I think certainly relevant, is the fact that the internal iliac arteries are diseased. The left internal iliac artery is completely occluded, as shown here, and the right has a high-grade stenosis with poststenotic dilatation. So not only do we have aneurysm extending along here, but with an occluded iliac on one side, a stenotic on the other side, it becomes important to take into consideration the revascularization of at least one of these vessels at the time of repair. And so it is important to recognize that the treatment planning really extends well beyond characterization of the aneurysm itself, but looking at the entirety of the access route as well as the branches to make sure that in the course of repairing the aneurysm, normal flow to other critical structures is not disrupted. Now, I just want to take a brief moment to bring everybody up to date on modern CT technology. Multi-detector row CT is what MDCT stands for. This is the same as multi-slice CT, which is a euphemistic term that I prefer to avoid. In the CT scanner, we basically have the simple arrangement of an X-ray source with a bank of detectors. These are so-called detector rows. In this particular schematic here, I'm showing you 4 rows that are being highlighted. Each of these are 1.25 millimeters in thickness, and so with a 5 millimeter beam, we would then simultaneously acquire 4 1.25 millimeter thick sections. When we highlight the entire width of the detectors, depending on the type of CT scanner we have, if we have a 4-row scanner, then we will group these detectors into groups of 4 and having 4 5 millimeter clusters. If we have an 8-row scanner, which simply means that the scanner is capable of pulling off 8 channels of information simultaneously, then we're able to divide this up into 8 groups or couplets so that they're each 2.5 millimeters. And with a 16-row scanner, we would be able to take the information independently from all 16 rows here. Now, with a 32-row scanner, this is not schematized here, we can kind of continue the analogy and go down to 0.625, and the current state of the art in CT is that the fundamental detector width is anywhere from 0.5 to 0.6 millimeters. And CT scanners are now available with up to 320 rows, although the 320-row scanner has a very limited penetrance and is still I would say relatively investigational. But 64-row is certainly a very common CT technology that's available broadly. The way 64-row is implemented is we have a 40 millimeter detector and a 40 millimeter beam and 64 by 0.625 millimeters. The reason why I spent a little time talking about this is that I did a little bit of a recent literature search to see what's appearing in various elements of the literature around state-of-the-art imaging. And there are still a number of articles that I see, particularly in the non-radiological or imaging literature, that suggest that state-of-the-art for imaging the vessels and the abdominal aorta in particular is at least 3 millimeters in thickness. And I want to stress to you that by creating a 3 millimeter thick CT scan or a 5 millimeter thick CT scan, that one is really throwing away information at this point in terms of the resolution that's available. And so right now with 64-row scanners, every scan is sub-millimeter resolution. And so for those of you who are clinicians who work with imagers and you are not seeing image quality like I'm showing you here today, it's important to interact with your imagers to be sure that they are taking advantage of the data and not just averaging individual sections to get you thicker sections, which is often what happens. This geometry is established to couple with a simultaneous table translation while the gantry rotates so that we get what's called a helical or a spiral path, so-called helical or spiral CT. This is a schematic of 4 rows, and this is basically how our CT angiography works at this time. And I'll point out to you that there has been a tremendous evolution. I mentioned 64-row introduced in 2004, that there is a progressive reduction in the section thickness and in the speed of the rotation. And the speed of the rotation has mostly had an impact on moving structures like the heart and in coronary artery imaging. But it simply also affects us by virtue of the fact that it allows us to cover large anatomic territories in a shorter period of time and hopefully in a single phase of acquisition. Back in 1998 when I did this scan on a 4-row scanner, it was a revelation to get the entirety of the abdominal aorta and iliac arteries in a single 30-second scan. But it was just a few years later that with 16-row we could image the entire body in less time than that. And so nowadays imaging an abdominal aortic aneurysm is not a challenge, and in the end, as I've mentioned, the spatial resolution should not be limited by the amount of coverage, and we should have a very high quality isotropic acquisition. Here you can see an example of another patient with an abdominal aortic aneurysm who also happens to have a horseshoe kidney. Oftentimes we will create short movie segments to convey complicated spatial relationships. This patient has 5 renal arteries, 1, 2, 3, 4, 5, and an inferior mesenteric artery very close to the neck of this aneurysm. being able to clearly define and depict these relationships is what's important in effectively planning the therapy for this aneurysm. This is a thoracic aortic aneurysm following stent graft repair. I'm going to talk about stent grafts in a moment, but I also just want to stress that looking at CT scans as a stack of transverse sections, while I think historically relevant and relevant from the perspective that we used to acquire a CT as a stack of slices that were thicker through the plane of acquisition, it's really an anachronism from my perspective for CTA because we have isotropic spatial resolution, equal resolution in all directions. And so while looking at this stack of sections, you can certainly see this big aneurysm, perhaps you can see a big endoleak. But what becomes challenging sometimes is seeing some of the detail that can be readily apparent when one goes to other computer-based visualization, such as this fracture here of this transverse ring and this fracture of this longitudinal strut of the stent graft, what maybe some of you saw in the transverse sections, maybe some of you weren't able to recognize. And so being able to fully utilize our various visualization tools really maximizes the information we get from these data sets. Here you see the multiple fracture points shown with arrows. Here you can see a reformation that allows us to track the path of the endoleak, the loss of columnar strength, slippage of the stent graft, opening up of a pathway for the endoleak to develop as it spirals around the aorta, as you see here, and then being able to go into the data and create whatever cross-section is germane to the anatomy of the patient. Here you can see the pathway of flow around the stent graft here, which is what ultimately results in its flow around the aneurysm and down into the aneurysm sac, as you see here. And then finally, one can even create immersive visualization. The tools to do this are no longer complex and expensive computers. This is done very quickly and easily in the reading room where we're just flying down this particular stent graft, and we can examine its structure from an internal perspective if clinically useful, and occasionally it is. Here you can see that fractured longitudinal strut, and by changing some of the settings I can eliminate the wall of the aorta and see the breaks in this particular stent graft, such as this transverse strut right there. One other feature of modern CT scanners is because of the improved temporal resolution used to image the heart and the coronary arteries is that now it's possible to look at some motion studies of the aorta. This can be done with MRI too, but here coupled with the high spatial resolution, you can see the changes in the position and movement of the neck as well as in the aneurysm across the cardiac cycle, and then following endograft deployment you can do the same study. And using techniques like that, I think a lot can be learned about fatigue and stress that occurs on endovascular devices after deployment, and also understanding the impact that these very stiff devices can have on the movement of the aorta and its branches. So with respect to treatment planning, the kinds of considerations that we think about are the suitability of the aneurysm for endografting, the type of endograft that's optimal, the size of endograft to be delivered, and the access route for delivering the aneurysm. Here is a patient, for delivering the stent graft. Here is a patient who has an extensive abdominal aortic aneurysm, and key to considering endograft therapy is the fixation of the device as well as its delivery. And having a suitable neck is really very important. So as we look at the neck here, this is a case of a juxtarenal neck where we see the extent of the neck coming up behind the renal arteries. This makes this very challenging. Even in the setting of having a stent graft with suprarenal fixation, we need to be able to have a seal point below. And so this type of anatomy and being able to display it with imaging is going to be an important guide for determining ultimately what therapy this patient needs. Now, other aspects of assessing the proximal neck, here's another stack of transverse sections, which gives you a sense of the tortuosity of this neck. But again, moving beyond those transverse sections and focusing on volume renderings, you can see just how much tortuosity and kinkage can develop in these patients. And this also has an impact on the selection of therapy and on the choice of an endovascular device. Even if there is a point of fixation here, one has to think about the torque that's going to be constantly applied to that device and the likelihood that it would be able to reliably fix at that point. Another circumstance, transverse sections. Here's the top of the aneurysm. This is the origin of the left renal artery. And as we look at these transverse sections and ask the question, is there a suitable neck? Is there enough space to deploy the aneurysm? It can be fairly difficult from looking at transverse sections alone. We always generate views that are orthogonal to the flow channel. In this case, we can see that the cross section includes the origin of the renal artery and the aneurysm, yet we can measure about a centimeter of length when we move obliquely along the axis of the aneurysm. And so based upon this distance, we can assume that there is sufficient space, or it was assumed that there was sufficient space for the stent graft. And here you can see that following deployment of the stent graft, the preservation of the patency of these vessels. If one relied exclusively on the transverse sections, it would not be sufficiently displayed and determined that the stent graft could be delivered. When it comes to actually accurately measuring and sizing the aorta, it's important to not simply rely on transverse sections as well. For example, at a level such as this, where the aorta is moving fairly perpendicular, or I should say parallel to the CT table, we get a reasonable cross-section of the aorta. But if we need to measure the neck at a region like this, for example, the aorta is substantially distorted. And so it becomes very important to be able to use workstation-based tools to reformat the data, to realign it so that we're in a coordinate system that is germane to the aorta itself and not to the table on which the patient lies. And we can get a very effective cross-section for measurement when we do that. And similarly, when we're measuring the length of the aneurysm, which is relevant for determining the size of the stent graft, it's important to not simply measure the uppermost and the lowermost sections, but to follow the lumen of the aorta. Now, fortunately, there have evolved tools that facilitate these types of measurements. Here you see another abdominal aortic aneurysm, and here, using a workstation-based tool that extracts a center line and straightens out the aorta, we routinely use very protocoled approaches to measuring key metrics. In this particular case, the length of the proximal neck from the renal artery to the origin of the aneurysm. You can see this patient has a bit of a tapered neck, which is going to be a challenge. But using these tools, one can very quickly measure the lengths of segments as well as the diameters and cross-sectional areas. And this is how planning of stent graft therapy has evolved with the availability of these tools. Of course, it's always very important to reference the measurements and the segmentation and manipulation that happens to the images back to the source data to assure that it's being done correctly. And these landmarks do not come up automatically. It takes a knowledgeable user to identify where the terminus of the aneurysm is and where its proximal extent is. I'll finally mention that there are a number of elements that are available from these high-resolution volumetric data sets for characterizing aneurysms that are not routinely used, that could even improve our ability to more effectively measure stent graft length, for example, and tortuosity, than we routinely use clinically. This was an algorithm that we developed a number of years ago that automatically finds the shortest pathway through an aneurysm as opposed to the median center line. All these automatic algorithms typically find a median center line path, which most of us know most stent grafts don't follow that path. They tend to find the shortest distance through the aneurysm. And so we showed in our publication of this work that we were able to more accurately determine the length of the path that the stent graft followed. So there is actually even more that can be done, but a lot of this has not been deployed commercially. Now, in my remaining time, looks like about 9 minutes, I want to talk about the post-treatment assessment. And following therapy, typically with stent grafts, because in that circumstance the surveillance of the patient becomes important, we're looking for 4 basic sets of findings. One is the presence of endoleak, of course, persistent flow into the aneurysm sac. Another is maldeployment. Another is any access route injury, and then ultimately, over time, the integrity of the device itself. I think oftentimes the endoleak becomes a very amplified and magnified focus of the follow-up of endovascular therapies for abdominal aortic aneurysm. But it's important to recognize that being able to assess these other elements, and particularly over time, I think this latter element becomes particularly important, and to recognize that our goal of imaging really follows all of these targets and not simply endoleak. I know that there'll be further talks about stent grafts, and that many people in the audience are very familiar with these. I just put up a couple of devices here, a couple of examples of infrarenal fixation devices, an example of suprarenal fixation. In all cases, the seal point is infrarenal, and the fixation point varies between these two. And I won't talk any more detail about stent grafts themselves. Here you can see a CT scan after the stent graft has been deployed. You can clearly demarcate the location and course of this stent graft. The metal does not result in substantial artifacts that hinder the visualization of the lumen. Now, if we consider MRI following stent grafting, I want to point out to you that here is an example of a patient that apparently has 2 occluded iliac arteries, but here's the DSA on this patient. This patient actually has an occlusion clearly on the left side, but on the right side there's a stent. And this particular stent is made from stainless steel. As it turns out, the type of metal that is used for an endovascular device, be it a stent or a stent graft, has a tremendous bearing on the effectiveness with which MRI can be used to look at the lumen and the tissues immediately around that device. Stainless steel, because of its ferromagnetic properties, has a very substantial impact on the image quality and resultant signal dropout with most MR pulse sequences. In contrast, nitinol, the nickel titanium alloy, which has become an increasingly used component of stent grafts, does not. And so consequently, when there is a nitinol stent, MRI can be done effectively. Types of things that we look for acutely include thrombus within the stent graft. This patient presented with a pulseless leg, and you can see that there is thrombosis within the stent graft. This illustrates the importance of being able to see inside the stent graft as well as around it. So if one has a stainless steel device, it would not be possible to diagnose this thrombus with an MRI exam. Also, it's important to be able to see clearly the metal of the stent graft, to know where it begins and where it ends. This is a patient who's receiving a thoracic aortic stent graft. You can see the aneurysm coming right down to the celiac origin here. This is pre and post-deployment. Following deployment, the stent graft covering the celiac, and now we have a thrombus developing because of the occlusion of the celiac artery. And sometimes our depiction of the relationship of the stent graft to aortic branches needs to be even more nuanced. Even when we create a cross-section, in this case of the thoracic aorta looking up at the left subclavian artery, that shows apparent coverage of that left subclavian artery, at least greater than 50% by the stent graft, it is again having high volumetric spatial resolution that allows us to get this internal view. This is a view from a camera, if you will, positioned within the aorta at this point looking up, and you can see the tines of this stent graft and how they align themselves around the ostium of the left subclavian artery, showing here that a substantially greater portion of the ostium is unobstructed by the metallic components than might be implied here. So I believe that this is the level of detail that one must have in analyzing these devices, and with a modality that does not show this level of detail of the stent graft, one is not necessarily going to be able to fully depict all clinically relevant findings. I mentioned the access route. It's very common to see hematomas in the access route. We certainly don't worry about those, but once we see irregularity around the access route, and here you can see a stenosis with a large collection. This is probably adjacent hematoma, but it is not uncommon to see some dissection or injury locally, and this is important to characterize as well. Here you can see another patient post-stent graft deployment who has a complex dissection of the femoral artery here seen en face, and here laterally you can see the false lumen coming here and the substantial narrowing. This patient had reduced pulses following the stent graft deployment and required repair of this segment of the artery. Getting even more severe, occasionally we see something like this. In this case, this was a thoracic aortic stent graft deployment. The patient had a large retroperitoneal hematoma following deployment after a conduit was sutured to the distal aorta, brought out to the skin in order to deliver the large thoracic endograft because the iliac arteries were too small. In addition to having this large retroperitoneal hematoma, some atheroma was mobilized during the course of passing the device up, and you can see the embolization and subsequent occlusion of the common iliac artery, also another important observation post-procedurally along the access route. One final access route point here, you can see some very irregular atheroma within the thoracic aorta following deployment of a stent graft. Here you can see actually before deployment of the stent graft, I'm showing you the kidneys. Following deployment, we can see these tiny little peripheral wedge-shaped abnormalities in the cortex. These are all small renal infarcts, which was associated with this blood clot in the urinary bladder at the uterovesicular junction. And so being able to see the extent of atheral embolism in that particular case and subsequent renal infarction, as well as even a more macroscopic splenic infarction that occurred in this case. So something else related to the delivery of the stent graft, not necessarily associated specifically with the aneurysm itself. Now, I mentioned endoleak as an important observation, and again mentioning that there's often a lot of focus on endoleak. Here you can see the flow around the limbs of the stent graft in this particular case. Here you can see a very common source of endoleak. In this case, it is from a patent inferior mesenteric artery here via the left colic artery, retrograde, giving a type 2 endoleak. Type 2 endoleaks, of course, are very common and very rarely are of clinical concern, as they rarely result in secondary enlargement of the aneurysm. I want to point out that in order to detect aneurysms as in order to detect endoleaks as effectively as possible, it's important to not rely on a single phase acquisition. It's well recognized that delayed phase imaging results in more endoleak detection. These are usually type 2s that are picked up late, but not always. Sometimes they can actually be subtle transgraft flow. This is one example of a study that illustrates that actually a 3-phase, both an unenhanced, an early arterial, and a delayed phase, optimizes detection of endoleaks. Here's an example of an arterial phase study that nicely shows enhancement of the stent graft. The aneurysm doesn't show an endoleak, except if you wait another 40 seconds or so, you see opacification of this lumbar artery, and then you will see visualization of the endoleak. If one is not using this type of approach with CT to follow the stent grafts, then with a delayed scan, then you will be missing endoleaks. I do want to point out, however, that MRI is an excellent tool for detecting endoleaks. In fact, there are a number of reports in the literature to indicate that MRI is more sensitive than CT for the detection of endoleaks. One of the advantages in MRI is the greater sensitivity of MR to the presence of smaller concentrations of contrast agent within tissue, particularly gadolinium, relative to iodine concentration within the aorta. And consequently, as time passes and relatively small amounts of the contrast agent have leaked into the sac, the MRI is more effective at identifying it than might be done with CT. The question that has not been established is, do endoleaks exclusively detected by MRI and missed by CT have a clinical impact? And that's something I think that's still an open issue. But I do want to stress that a lot of studies where comparisons are made between MR and CT don't always take advantage of all of the approaches to demonstrate subtle endoleaks, and they can be very subtle on CT. Here's an example of a patient. This is the arterial phase, this is the delayed phase, and here is the subtle endoleak. This was just this actually patient was diagnosed with endotension until the CT was well scrutinized, and you can see the subtle egress of contrast here. Here you can see an earlier scan, and here a subsequent one which shows some transgraft flow in this particular case. Now, just this year, there was 3 cases published in the Journal of Vascular Surgery where they actually did 30-minute delayed MRI, and you can see in all these cases a small bit of gadolinium coming out around the endograft. In this particular case, these patients had all been characterized as having endotension without the presence of endoleak, and I think this is a nice demonstration of what I was referring to, of the sensitivity of MRI to detect very subtle endoleaks in this particular case. What's missing from this study, unfortunately, is an intermediate delayed phase scan to see whether or not it would have picked that up as well. Now, I did mention that in addition to looking at the endoleak and in addition to looking at the access route, that the actual integrity and success of the deployment is important. And this is an example of a scan that clearly establishes a problem with the deployment of the device. When we see 3 limbs, then something is wrong. And in this particular case, you can see a very funny configuration here, almost like a biconcave disc with another limb adjacent to it. And here's a stack of cross-sections showing you what's going on. Those of you who are familiar with looking at these data sets hopefully can understand the abnormality here, but I'll explain it to you, and that is that this is a modular stent graft where the primary device is the full long limb on one side but a short limb on the other, into which the secondary device is to be placed. In this particular case, that secondary device didn't make it into the gate or the secondary limb. It was deployed adjacent to it. And consequently, if we follow this limb up, we'll see that instead of engaging in the stent graft, it goes adjacent to it and distorts it. And this is a big problem because now we have a direct conduit down the stent graft into the aneurysm sac. Here we are on the short limb, and it just pours contrast into the aneurysm sac. So this detection of this maldeployment is something that the CT will effectively allow one to do. And here is just a volume rendering showing that blind ending or terminating short limb where the flow is coming through. And here's the endoleak effectively filling the stent graft. But beyond that, over time, we know that these devices have a tendency to break down and fail. And this is an example here of what we are observing with some increased frequency. This overriding appearance here, or in fact, this frank disruption. In this particular case, an example of stent graft fracture. Here you can see the volume rendering where you see multiple interstices are fractured, opening up of the device, loss of columnar strength, which actually results in migration of the device. Here you can see a baseline study, the relationship of the proximal, or I should say the anterior and posterior limbs of the proximal end of the device. And you can see the movement of the anterior limb after that fracture occurred, the development of a huge endoleak and actually enlargement of the stent graft. Now, the follow-up of stent graft integrity has been largely relegated to projectional radiography. And here's an example of some subtle fractures. But we're finding more and more with the quality of current state-of-the-art CT that these observations are as effectively, if not more effectively, detected with CT than with radiography. And that largely relates to the many challenges of getting diagnostic radiographs. Here is a number of the challenges when assessing and following stent grafts. I'm running out of time. I just want to briefly mention one aspect that should be in everybody's mind about safety of performing these studies. With CTA, main considerations are radiation and iodine exposure. With MRI, magnetic fields and gadolinium. For the age group of patients with AAAs and with the comorbidities and their life expectancy, radiation is really not an issue unless we're talking about some of these genetic disorders in younger patients. Magnetic fields become an issue in patients who have implanted devices if they have coexistent cardiac disease and pacemakers, but otherwise is not a very common consideration in AAA as well. It really comes down to the contrast agent in general. And because of the fact that a lot of these patients can have renal dysfunction, we've recently come into some challenging times because both iodine as well as gadolinium present challenges to us when patients have renal dysfunction. And in particular, for those of you who are less familiar with the issue about gadolinium, and particularly I just kind of want to jump down and mention that the recent understanding and introduction of nephrogenic systemic fibrosis and its impact in patients who have limited renal function. Here is just a quick sort of summary of which kind of patients get it. All patients have received gadolinium, and in particular, when you look at the subset who get NSF, a substantial number of them are those who have had vascular access procedures. So for our population, potentially, particularly following up aneurysms, people who have limited renal functions, NSF is something to be aware of. Fortunately, there are techniques to image with MRI that don't require gadolinium. In general, when we use these types of techniques, we're limited in terms of the image quality compared to what we can do when we have a gadolinium-enhanced exam. But we can also use unenhanced CT. We can't measure an endoleak or detect an endoleak, but we can very effectively look, and this is a case where we're imaging. This one has contrast, this one does not. This patient has a migrating stent graft. This is the superior mesenteric artery. Here it's gone from 6 millimeters to 15 millimeters, and here's a view of a 1 millimeter distance from the renal to 12 millimeters. So this is diagnosis of a migrating stent graft following use of unenhanced scanning. So let me summarize as follows. Sonography is the best tool for the detection and assessment of the progression of aneurysms. I didn't spend a lot of time on this, but hopefully others will be able to touch upon this. In our center, CT is the first choice for treatment planning and post-treatment assessment, but MRI's primary advantage, particularly following stent graft deployment, is its sensitivity for endoleak, and at times can be very useful. And as you will hear in subsequent talks, MRI and scintigraphy have tremendously exciting roles in characterizing the progression, evolution of the disease from the perspective of analyzing the biology of the wall and the function of the vessel. And hopefully someday soon these considerations will enter into our clinical practice and management of aneurysms. I want to thank you all very kindly for your attention.
Hi, Jeff. That was great. The images, as always, are just really spectacular, and you really do feel like you can dive in and see in real detail what's going on. We're running a little bit behind on time, but I know Jeff won't be able to stay with us for the rest of the session, so maybe we could take one question.
Hi, thank you for that talk. Just a quick question. In your experience, how prevalent is the mal-deployment of stent grafts, and what intraoperative imaging technologies would you like to see in the future?
Well, it's not very prevalent. It's unusual to see a case like that. I've seen 3 of them in my career, so it doesn't happen very often. But mal-deployment from the perspective of branch occlusion and suboptimal deployment, we've seen more frequently. Obviously, it varies a lot with the device and with the experience of the user, and I think that back in the 1990s when everyone was just getting initial experience with devices that were perhaps not as easy to use, we saw it more frequently. I think it does speak a bit toward using effective imaging to guide the procedure in several circumstances where I've actually observed the mal-deployment occurring. Oftentimes, for various reasons, the operators were in a rush and didn't necessarily do everything they could to assure, for example, that they were engaged in the gate before deploying the secondary limb. I think everybody who deploys these devices, I'm sure, understands the necessary steps to do this safely. And as long as one follows those guidelines and makes careful checks, then it shouldn't be a problem. The one other thing I will mention, though, that has been useful is that because of the angulation of the aortic neck can be substantial, particularly relative to the table on which the patient lies, we have used measurements from the CT scan to determine the angle for the C-arm during guidance of deployment in order to lay out the neck and to get the best view truly perpendicular to the neck and see its relationship to the renal arteries for the initial deployment.
I have a question about using imaging for spatial or for motion characterization. And you said the best spatial resolution is about 0.5 millimeter with CT. So what are your thoughts about using CT to get pre and post dilatation measurements after an endograft's placed? And some recent publications have come out on that, particularly Hans Verhagen's group out of the Netherlands.
Yeah, no, I think that it's very intriguing, and you referring in particular to look at pulsatility of the sac and such. I think it's a very reasonable thing to do, and as you've indicated, there's some preliminary data on it, and ultimately I think we want to find out whether or not it has a clinical impact in the management of these patients, because when you gate, you do give some things up, and the image quality for the static images isn't necessarily going to be as high, depending upon the type of CT scanner you have. Also, you're going to be delivering substantially more radiation to the patient when you do those gated acquisitions.
Is serial imaging something that is common to follow up maybe the endoleak?
Well, certainly serial imaging is a part of following up endografts in general and endoleaks, and depending on what type of endoleak, the serial imaging might come at greater frequency. A lot has been written on protocols for serial imaging, sometimes alternating CT and sonography, sometimes relying more on sonography and other times on CT. And I think it's kind of hard to give very specific hard and fast rules about it. And my sense is that whereas initially when stent grafts were first made available, people followed very strict protocols, now a lot of times it becomes a little bit site-specific and sometimes ad hoc, and obviously very dependent on a patient's willingness to follow.
So site-specific, in your case, do you do serial CT imaging in less than a year?
In many cases, we do. Maybe, but again, I would say it depends very much on who's deployed the device, because ultimately we don't order the follow-up scans. Ron, maybe you want to comment on how frequently you survey.
It's very patient dependent on the situation.
Do you have concern about radiation in that case? Because that came up actually in one of our medical grand rounds, and Mike Marin, our surgeon, in terms of using CT like this serially.
Well, I think I'll just say one thing about that. It's very important to consider the fact that right now there are no mechanisms whatsoever to track serial radiation exposure in any patient population. And I think that it's important. I mean, we track use of medications and many other therapies where this is relevant. Again, I'll just hearken to the fact that most of these patients are in an age group where even with serial radiation, it's unlikely to have a biological impact on them or an impact on their health. But in a larger, grander scale, we absolutely need to get a better handle on serial exposures.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.